outbreak of salmonella somewhere in Manly, you don't say that the cause is somewhere in Manly. You say it's a restaurant in Manly, and then you go and look at the restaurant and you look at the food and you come up with the chicken and you work out exactly where that comes to. When you're dealing with chronic diseases, you have to do the same thing. You can't say, well, this is the disease, these are the risk factors, therefore let's finish there, just treat the risk factors. If we take it back to the proximal causes, the immediate causes, things like smoking, diet, inactivity, unsafe sex are all causes, but they in turn have causes, because people don't smoke for no reason. They smoke because of stress, anxiety, depression, and there are medial causes there that drive these proximal causes, which drive the risks, which drive the disease. And we can go back even further to the distal causes, and the distal causes in this case is the industrialisation, modernity and economic growth and the system in which we live. Now, don't get me wrong, I'm not suggesting that there haven't been tremendous benefits in economic growth, but what I am saying is, and this is reflected now in economics as well as in health, that we have reached a point where we're getting diminishing marginal rates of return, speaking in economic terms, so that the health gains that we are getting from the extra economic growth that we are getting simply by paying bankers more and selling more ducks to each other is starting to become negative. So we have to look at the big picture. That's what lifestyle medicine, in my view, is about, looking not just at the immediate causes, but at the big picture as well. So if we take all those causes of changes in health, and Tapigranatis from an economic perspective said, why in a recession in Japan would they get healthier? And why in good times would they get less healthy? And he isolated the behavioural causes, such as these: traffic accidents, cardiovascular disease, alcohol and smoking, and so on. And you take that back in the way that I've just done, and you wind up with economic growth. So why the need? I'll answer the first question. Why the need for yet another new approach in primary care? Because disease patterns change dramatically with economic development. And until we get the economists thinking of economics as a dynamic science rather than a static science, and this whole notion of pouring more money into the system now to try and prop it up, rather than looking at the system and saying, maybe we've got to look to a new system, or look to a new way of measuring that system, at least in the first instance, because that's related to health as well as to economics, and that's where we need to broaden our vision on all that. So the second question was, is there any underlying biological basis to what is essentially a behavioural, environmental etiology of chronic disease? And this is where I hope to answer Norman's question, and I think I did on radio when he was dialing for his lunch there that day. Let's take obesity as an example. Now, Australia is ranked about number 5 or number 6. Don't take any notice of the study that was published in Melbourne last year, done in a shopping centre, where the Australian came out and said that we are number 1 in obesity. We are not. This doesn't even include the Eastern European countries and the Pacific Islands. We're about 15 or 16 in the world, but we still have a problem. People are obese. But is that obesity really an issue? John Dixon and I said in a paper that we've just had come out electronically, obesity is collateral damage in the battle for modernity. It's the burden many of us bear as a result of our inability or unwillingness to adjust to the energy surpluses emanating from economic advancement. So in some senses, obesity is a voluntary disease. In the other sense, as Norman pointed out, quite rightly so, it's involuntary in the sense that poor people suffer from it more than rich people. And it's not a disease of choice in that case. But to some extent, obesity then indicates what's going on in the society and what's going on in the community. And going back, and I've worked in obesity now for quite a while, going back, if you look at the models of obesity and disease, you'll see that there are 3 or 4 different models. The first one said that obesity causes disease, and it's mainly heart disease. It's purely and simple, and that goes back 2,000 years. If you get fat, you get sick. We knew that that was wrong because we find fat people that aren't sick, as Norman pointed out. The second model then that came out of France in the 1940s was by a French endocrinologist by the name of Jean Vargue, who said that maybe it's where you're fat that's important rather than if you're fat. So if men with abdominal obesity were much more unhealthy than women with gluteal obesity, and that's been proven over and over again. But that still doesn't explain everything, because we get, as I know with the men that I work with, we get men with big bellies that have no risk factors. We get men with no bellies that have the risk factors that you would expect of the men with big bellies. So that doesn't work. In the 90s, we said, well, okay, maybe it's visceral fat, it's internal fat. It's not just the subcutaneous big belly. You can get thin people with internal visceral fat around the kidneys and the liver and the omentum and so on, which drains very quickly into the portal circulation, which is very lipolytic and therefore very atherogenic. Maybe that's the problem. And we know that it is. We know that visceral fat is a very significant indicator of type 2 diabetes, heart disease, and lots of other problems. But it doesn't solve doesn't answer all the questions, because there are still people with high visceral fat that aren't necessarily sick, and still people with low visceral fat that do have other problems. So there's something else in this, and the question is this always a problem, or is this never a problem? If you're fat, and particularly around android obesity around the waist, and if you're lean, is it never a problem? So let's look at that. Well, there's been several papers published on this now, and we know that some obese people are metabolically healthy. They're called the metabolically healthy obese. They've actually got an acronym named after them. And it's probably in fact, the figure has gone up. It was thought to be about 18%, but it's gone up now to 30 to 35% of obese people are metabolically normal. On the other hand, you get lean people who are more like the obese. They are metabolically obese, normal weight, or the MONWs, MONWs. And again, we thought this was about 17 or 18% of the community. A couple of recent papers published show that it's about 1/5, about 25% of lean people have the metabolism of somebody that you would expect that's obese. So there's something else going on in there. And Time magazine, Journal of Clinical Investigation, some of the popular magazines started to get onto this recently and report this notion of inflammation as being important. Now, let's step back a bit and talk about what inflammation is, because Aurelius Celsius, a Roman physician, first noted the signs of inflammation, and anybody that does classical medicine will be taught that the Kala, Dala, tumour and rubor, the main signs, and loss of function are classical inflammation. That occurs when you are invaded by a microbial organism and your body responds to a cold or flu or virus or something. It happens quickly and then it disappears. Until recently, no one would have envisaged that inflammation could be a root cause of metabolic abnormalities associated with obesity, or a potential molecular target for diabetic therapies. So if we go back and look at classical inflammation and you look at how it occurs, the body is in homeostasis, it's invaded by a foreign stimuli, it sends out a warning signal, and we can measure this through pro-inflammatory cytokines, and I'll show you a really interesting study that we've just finished at Sydney Uni on this. There's an inflammatory wall built around that invading organism to stop it from spreading. You get a defensive action, then you get the clean-up signals from other parts of the immune system, and then finally the stimulus is removed and the body returns to homeostasis. So we go through homeostasis to allostasis to homeostasis, and that can happen all within the course of a couple of days, or at worst a couple of weeks in the acute injury situation. And we thought that that didn't really happen with chronic diseases and lifestyle-based diseases. We didn't know what the cause was, but it certainly wasn't associated with the immune system. In 1994, a guy called Gurkan Hödemizligl from Harvard University, I think he's Finnish, published a paper showing that obesity is also a form of inflammation in the arteries. It's low-grade, it's systemic, it runs right through the body, and it's chronic, it's long-term. Because it doesn't stand out as much as an acute infection, when you measure the markers for chronic inflammation, they are 4 or 5 times normal level, whereas if you measure the markers, say CRP, in the case of a cold or flu, it can go up to 200, 300 times. And that's why we didn't pick this up early. But if you look at this type of inflammation, what happens? It happens in the arteries, and it happens in the artery wall. And first of all, you get endothelial cell injury there in the artery wall. It can happen through a number of different ways, and I'm going to talk about what ways start this process. But then you get oxidation of LDL within the artery wall. That is then attacked as a foreign body by a macrophage, part of the immune system, which recognises it almost as if it was a bacterium. Then you get foam cells built within that artery, which they call foam cells because it's the product of the macrophage attacking the oxidised LDL. That then is fine whilst you get the migration of the smooth muscle cells to the top of that. It forms a fibrous cap over the top of the foam cell. But then, if that bursts into a thrombus and bursts into the brain, then you can get sudden death. And this probably explains a large proportion of those heart disease deaths that we can't explain by the classical risk factors such as cholesterol and blood pressure and hyperglycemia and so on. So this type of inflammation, Hout Omisligal called it metaflammation because it's inflammation within the metabolic system. There's a war going on between 3 different universities over there at the moment, Harvard, Yale and